Thank you, Madam Chair. Thank you, commissioners. Thank you to my staff for coming in. Thank you to our colleagues at the Health Policy Commission for joining us, who we'll introduce in a moment. Other attendees who have joined us. I am thrilled to be back in person. It's great to see you all. I was talking with folks in the hallway before we came in. I want to say it's felt like just yesterday that we were here, but it does not feel like just yesterday that that we were here in person. But it is really, truly great to see you all in person. I do just want to give a quick thanks to my staff for pulling together the details of today's meeting. We're flexing muscles we haven't used in quite a while, and many people who were not even on staff at that time. So in particular, I just want to thank Emily Williams, our Chief of Staff, and Maureen Quinn for just pulling together the details. And we have some colleagues from EOTS, Nicole Porter, I think, and Matt Naughton from EOTS, just assisting us because we are recording the meeting. One of the great benefits, I think, of virtual meetings is that we were able to broadcast those meetings live for folks to view. And we actually had really good viewership during that time. So we did feel it was important that we, at very least, tape the meeting and to be able to post it on our YouTube page. So with that, let's jump in. We've got a busy agenda for today. You all have materials and the slides in front of you. We also have them projected here. I'll do a quick review of our Executive Director's report. And then we'll be happy to turn it over to my colleagues David Seltz and Dr. David Auerbach from the HPC. Of course, this is an annual feature of our meetings this time of year, and really marks the beginning of our work with you to prepare for our fiscal year 25 coverage. So we'll be back in December to start to talk about aggregate annual rate increases, but we always want to start first with an overall view of the healthcare system, the challenges that we face at the GIC, but everyone faces in the healthcare and health insurance marketplace, and there's really no one better than our colleagues at the Health Policy Commission to help us understand that broader context. So we'll do that, and that was really why we chose this meeting to have as our first in-person meeting, because this always prompts really good dialogue, and we thought in person really made the most sense for this meeting. After that, we will have turn it over to Jim Rust, who will walk through the procurement recommendation for audit services for our health plans, and leave it with Jim for our CFO report. So that's what our agenda is for today. So happy to move on. Yep, we got to do the minutes. Give it back to you.
Yep, thank you, Matt. So at this point, to get into the meat of our meeting today, I'd like to make sure that we have reviewed the minutes from the meeting on September 21st. I will be abstaining. As you know, I was not here, but thank you, Madam Vice Chair, for ringing on time.
Put yourself on mute, Bobby.
She's a very busy woman. She chaired our meeting last month, so I was not here, so thank you. But at this point, I know you all reviewed the minutes, and I'd like to have a motion to approve them. So Eileen, second. So all in favor can raise their hands now. All in favor of approving the minutes? Anybody against? And then abstaining for those of us who weren't here. Does the motion pass?
Motion passes.
Motion passes. So at this point, I'm going to turn it back over to Matt. And as he said, we are recording this to live stream it. I love the transparency. I hope it further engages our constituents and they become the best consumers of healthcare and they buy the best insurance for them. So if these meetings help them see the good work that's being done here and motivates them, all the great work recording is for it. So if you do need to speak, we use this. And I've been told that Emily will sashay around the room and give us the mic. Not quite sashaying, I added that. Okay? There you go.
Great. Thank you, Madam Chair. So for the Executive Director's report, as always, we have provided you with a written summary. I'd like to highlight just a few items before we hand it over to our colleagues from HPC. On the human resources front, we continue to be very busy working with Brock Weidenheimer, our Director of Human Resources. I think we talked a little bit about this in a prior meeting. We've put together a training for our operations staff. One of the things that's very important to me and to the leadership team is to make sure that we support our staff, particularly those that interact with our members on a regular basis in the work that they do. So we partnered with NAGE to bring a training for customer service skills, and in particular, kind of general phone customer service skills and dealing with difficult callers, which when you're dealing with health insurance is likely to happen from time to time. So I want to thank NAGE for their partnership in bringing that training to us. Very well received from the staff, and the participation was very high. We also, on the HR front, have 2 positions posted, an executive assistant, which we've been without really since Janine Hines left us quite some time ago. So this person will be, of course, supporting me as executive director, but really the whole leadership team and even more broadly across the organization. So somebody you'll likely see in future meetings. And then we have a new Auditor 2 position that we've posted, also in the operations unit, and really frontline dealing with members as they navigate billing and benefits. So fair amount going on in the human resources front. In the municipal space for us, something we talk about a good deal here, Mike Berry, our Director of Legislative Affairs, who also oversees our municipal work, Mike, thank you, has been very busy. We've had a fair amount of interest, kind of a notable uptick, I would say, of interest among municipalities to evaluate joining the GIC. So Mike is responding to those inquiries, doing presentations about the benefits of joining the GIC. I'll probably join him at 1 or 2 of those. So that's some important, exciting work that's ongoing. This leads up to our December 1 deadline for municipalities to notify us of their intent to join. And finally, on the communications front, we have Leslie Montero, our Director of Communications, here today as well. And I won't go through every element of the comms update here, but we do want to continue to update you in a fair amount of detail about all the efforts that we're making on the communications front. A lot of that in the months ahead will be focused on preparing for annual enrollment for the spring. So thank Leslie for that at Erica's direction. So that is the Executive Director's report highlights. I'm happy to take questions on any of that or anything else that appears in the written report. Go ahead, Bobby.
I just have a question, probably to Mike, regarding the school districts, the interest. Like, would that, if they decided to join, would that most likely be next year? I mean, for December of '24, as opposed to, like, there's not enough time for them to come in this year, is there? Anyway, I guess my question is whether there would be sufficient time this year for them to meet the deadline to come into to join GIC if they wish to, those regional school districts.
Thank you. So I think the question is, Bobby, if I can summarize, if a municipality wants to join us and they give us the go-ahead December 1st, is there enough time to meet open enrollment and starting in the fiscal year that starts July 1?
My staff can confirm that for me, but yeah, the December 1st deadline is for entrance to the GIC for coverage effective in July 1st of the following year.
Right, but these districts that express interest, right, would there be enough time, because December 1st is, so there would be
They'd
still.
have to tell us now.
They'd have to tell us like now, so, right, right. So I guess I meant, like, are they close, that close? Let me put it that way. Or you can't say. Like,
Well, I don't think we know until
Oh.
they inform us, right?
Oh,
All we
okay.
have is the inquiries, and we
Okay.
provide information back to them, and then they notify us by December 1st.
okay, all right, thank you.
Any further questions on the Executive Director's report? Seeing none, I think now, Madam Chair, we'll just take a quick look at the calendar. This will be quick because we are coming to the end of the calendar year. We will, incidentally, for future meetings, I think we're going to adjust the format here to be more of a fiscal year format, which is really the way that we operate as an organization. I think it would make a little more intuitive sense. But as you'll note here, in addition to today's agenda that I've already recapped, we will be back in December for that first look at the overall projections as they stand, well, will stand at that point for what our premiums are likely to look like for the coming year. So we look forward to that. And at the December meeting, of course, and in the deck for that meeting, we will have a longer view tentative calendar for 2024. So that's the calendar. Happy to take questions on that.
The only thing I would say, Matt, is, and to your staff, if you do want to match up with the fiscal year, you may want to start in December to show that look, because it really starts December meeting with the rates through the fiscal year. So you almost have to have like an 18-month look, and that slide will get busy.
Well, it won't be the next calendar you see won't be a full 2024 calendar year.
Okay, so you'll break
the
it.
first 6 months, first half of this slide to the right, and then the remaining 6 months for
Okay.
the fiscal year.
I think that would be helpful, although we have a seasoned board here who understands that. But for new members who may be joining, it would be helpful.
Yep.
All right, great. And the December meeting will be virtual, so we will be back on Zoom, and hopefully we'll hear more in December about the in-person meetings, because you'll plan them for the year potentially.
All right, thank you. With that, happy to move to our first agenda item and introduce our colleagues from the Health Policy Commission. So I want to give a warm welcome to David Seltz, Dr. David Auerbach from the HPC to present on their view of cost trends. This, as I said, marked the beginning of our look towards FY25. And you know, I think we're really uniquely fortunate in Massachusetts to have an agency like the Health Policy Commission to do the work that they do. I think the depth of talent that your staff has and the leadership that you bring really is uniquely helpful to me. I go to meetings of my colleagues in other states, and there aren't many that have what we have, certainly not to the degree that we have it. So this is the 10th year that the HPC has put together their cost trends report. Just recently had their hearing. Was that last week? I think it was last week. So thank you for carving out time on the heels of that. I'm sure it's a major undertaking. But what David and the team there are really able to do is to do real deep analysis of important trends in the healthcare system as it relates to affordability, behavioral health access, health equity, all the things that we care about. I've joked, I don't know if I've joked to David, but oftentimes we follow the work so closely that, you know, I'll type into my computer mass.gov, and instead of it automatically pulling up GIC, it'll often pull up the HPC's website. We check it that much. So, David, thank you so much for joining us. Look forward to your presentation.
Great. Good morning, everyone. Thank you so much for having me here for this first in-person meeting. I didn't quite realize that this was going to be your first in-person meeting in 3.5 years. So I will try to bring some energy this morning, and I'm really excited to be here. And thank you, Madam Vice Chair, for helping me understand why there's 2 microphones up here. I do feel like I've been called before a congressional inquiry right now, so please be gentle. I just want to start with just a note of gratitude to Matt and the team at the GIC. I think as another independent state agency working in healthcare in Massachusetts, we have found friendship and partnership throughout the years, but especially in the last 3.5 years. Whereas directors of agencies with staffs really trying to navigate how do we conduct our work in a way that meets our goals, conduct our work in a way that's transparent, support our staff, thinking about office space and remote working. And it's just been such a privilege to have a cohort of state agencies, GIC and the Connector and the Center for Health Information Analysis, all independent agencies that we've been able to kind of share best practices and share learnings from. I will share with you all that at the Health Policy Commission, while we have had a couple of all in-person special events, our regular board meetings have been a combination of totally virtual or hybrid. So we have not had one of our regular board meetings as an all in-person board meeting in the last 3.5 years. So I look forward to hearing from Erica and Matt and the team here about how this went so that we can learn from that as well. And I think in the spirit of sharing information. It's a great time for me to be able to present before this commission because the Health Policy Commission, as Director Vino said, we just released our annual report and just had our annual hearings. And so what I wanted to do today for you is first just provide a little bit of background about the Health Policy Commission and the law that established it and our efforts around healthcare cost containment. Just by way of background, I see a lot of familiar faces around this room who I know the story of the Health Policy Commission, but I see some new faces as well. So just wanted to orient you all to the work of our agency. And then I'm going to turn it over to my colleague, David Auerbach, who's the director of our Research and Cost Trends team. He's going to provide an overview of some of the key trends that we are really keeping an eye on in terms of spending trends, pricing trends, and utilization trends in this very, very dynamic healthcare moment that we find ourselves in. And then I'll close out with just a few remarks, sharing some of our policy recommendations that we've made to the legislature to update and modernize our approach on healthcare cost containment, including to put a greater emphasis on affordability for residents and families and employers in Massachusetts, and also to reduce health inequities in outcomes and access. So by way of background, the Health Policy Commission was established 12 years ago by an act of the legislature, a comprehensive piece of legislation that really was focused on moderating the growth of healthcare spending in Massachusetts. This law was really part of a series of laws and reforms. Again, I see many familiar faces around the room who are a part of some of those reforms, but a series of reforms really beginning in 2006 when Massachusetts became the first state in the country to have a universal healthcare access be one of its key goals. Subsequent to that effort, that successful effort, we still lead the nation in the lowest rate of uninsured. There was an increasing focus on understanding cost drivers and spending drivers, and to think about ways that we could maintain that promise to our residents and employers that they would have access to affordable health insurance. And at that time, in the late 2000s, we were seeing, kind of an acceleration of healthcare spending. Some of the year-over-year increases were in the double digits. And this was causing an incredible challenge for both state government including through the GIC and Mass Health, to be able to continue to provide great benefits to the members of those programs, as well as obviously employers, families, individuals. Whatever wage growth individuals and families were feeling at this time was being completely swamped by increasing healthcare costs. And so the legislature and the administration came together to really pass another comprehensive piece of legislation to tackle this new challenge. And the centerpiece of this new legislation is this idea of a healthcare cost growth target. And what that is, it's an annual target for how much we as a Commonwealth would like to see total healthcare spending grow. And to help monitor and to guide that effort, it established a brand new independent state agency in the Health Policy Commission. I was working in the state legislature at the time that the bill was passed, stopped and worked for Governor Deval Patrick for a short period of time, and then became the first executive director of the Health Policy Commission and employee number one about 12 years ago. And so on the first slide here for us, one more. Thank you. It's just laying out a little bit about this law, this Chapter 224 law, and our vision for the future. Next slide. So I want to say a little bit more about this idea of a healthcare cost growth benchmark and what is this tool that we have leveraged here. The first thing I would say is that it is a prospective target. It's something that now the Health Policy Commission board meets annually and sets a target for what we would expect the healthcare market to be able to achieve in terms of moderating spending growth. So for example, earlier this year, in March 2023, we set the healthcare cost growth target for calendar year 2024. So we're looking at the year-over-year growth between 23 and 24, and we set that target at 3.6%. That is the target that we hope and expect that payers and providers will work towards to be able to moderate that growth year over year. At the same time, I want to be clear that it is not a cap. It is not a hard cap. It is a target. And there have been years, and we will show you the results over the last 10 years. There have been years where as a state we have exceeded that target. And there's been years when we've been below that target. And that's a feature, not necessarily a bug. Because this really is intended to be a long-term strategy. There may be given unique circumstances in one year that could drive spending up. There may be unique circumstances in one year that would drive spending down. I can tell you in the first year of the pandemic, 2020, we actually had negative healthcare spending growth year over year. And guess what? The year after that, very high growth in healthcare spending. That was very clearly directly related to the closure and of certain in-person services in 2020, and of course the rebound in the year after. What's important about the benchmark is understanding kind of what's driving it underneath. It becomes a organizing principle that we at the Health Policy Commission and then other state agencies can organize their policies and their programs around. And so that benchmark has been used by the Department of Public Health in some of their market conditions that they've put on certain mergers. It's been used in other circumstances across state government as kind of a universal target that we should be working towards. As I said, it's not a hard cap, either kind of total statewide or on any individual provider or health plan. However, there is an accountability mechanism. So at the same time that we're setting targets for the future, we are retrospectively reviewing the performance of health plans and providers and evaluating their spending performance against that benchmark. And each year, we confidentially review each individual provider and payer contract on a contract level basis. So provider A's Blue Cross Blue Shield contracts, or provider, MGB's payer Y contract, and look and judge and understand if the spending is above benchmark. And if that Health Policy Commission, in the course of this review, determines that the spending is above benchmark and is excessive, and that the entity can do something to adjust their spending, to moderate their spending, the Health Policy Commission can require a performance improvement plan. And the performance improvement plan is an 18-month plan that is designed by the entity that's being targeted, again, either a provider organization or a health plan, where they commit to a series of interventions and strategies that would reduce their spending growth. To date, the Health Policy Commission has required one performance improvement plan. We required this last January. It was filed with us over the summer. We had some back and forth. And then last fall, we approved the first performance improvement plan for Mass General Brigham. The Mass General Brigham is now currently implementing that plan. The target savings for that plan over an 18-month period is around $175 million. So we are closely monitoring today and evaluating their performance on that plan, and have to, at the end of the day, the commission must decide whether the plan was successful or not, and can it go so far as to require a second plan or an extension of the plan if we find that it was not successful. Also, I think just worth noting here, again, to emphasize, when we're measuring year-over-year spending growth, we are measuring all spending in the Commonwealth. So it is Medicaid, Medicare, Medicare Advantage, commercial insurance, GIC insurance, all of that spending is being calculated as we measure year-over-year growth. In addition, copays and deductibles and what patients pay out of pocket is also included in that calculation, as well as kind of the administrative costs for health insurance plans. And the rationale between that kind of all-in metric is that if we're not measuring it, we won't be able to see whether we're seeing shifts underneath the statewide target. Are we seeing different trends in the commercial space than in the Medicaid and Mass Health space? And that may adjust our policy recommendations accordingly. And so it's important to know, kind of see the full picture and then be able to dive deep underneath. Next slide. This is just a quick reminder. We were planning to present today with our colleagues from the Center for Health Information and Analysis. I think they're going to present to you at a future date. But just want to highlight that the law, in addition to establishing this new Health Policy Commission, also reformed an existing state agency called the Division of Healthcare Finance and Policy into an independent Center for Health Information and Analysis. I think the important point from this slide, and there's a lot of words here, but think of CHIA as really kind of the data hub, the data repository for our incredibly rich information that we gather from health plans and providers, including a very powerful all-payer claims database that includes claims from GIC members that we can isolate and evaluate. And they issue a number of very standard kind of annual reports monitoring and tracking our progress. The Health Policy Commission is more of the policy hub. We use data a lot, as you will see, but we use our data more in kind of tailored analyses to answer specific policy questions or to help us really craft policy recommendations both for ourselves, for other state agencies, and for the legislature and administration. So we bring more of a policy recommendation and a policy lens to this work. Next slide. So all of this wraps together into our mission statement, which you can see here. I would note the kind of orange text here is text that we amended in our mission statement in 2020, recognizing the critical and instrumental link between health equity, affordability, and cost containment, and wanted to reflect that commitment to health equity in our mission statement and vision. And so some additional words were added there. But I think the broader point here is really around better care, better health at a lower cost. It has to be all three is really what we're trying to get at. If it was just around saving money, there are pretty direct ways you can do that that would ultimately be pretty painful for residents and members in terms of their ability to access care, to have high quality care. And so, we could increase the deductibles for everyone and we could save the system money, but you're really just cost shifting and causing challenges. And so it really has to be finding those strategies that can meet our kind of triple aim goals. How do we improve the health of our communities and residents? How do we improve the experience of care? And how do we moderate spending growth at the same time? And I know I keep saying that, but I just want to emphasize again, we're talking about moderating growth. We're not actually talking about absolute cuts in healthcare spending, because our healthcare system is important and needs to continue to grow. But should it grow so much faster than every other part of our economy? And that's really one of the goals of the HPC. Next slide. So I just want to take a minute just to share with you a little bit about our kind of structure. So not so dissimilar from the Group Insurance Commission, it is a board-run organization. So as executive director, I report to a board of 11 commissioners. These 11 commissioners are appointed by the auditor, the attorney general, and of course the governor. These are, like many of you, citizen public servants. These are people who are not full-time employees of government, but really have areas of expertise that their appointing authorities appoint them to these positions to help guide the work of our agency. And each one of our board members, again, not so dissimilar from the Group Insurance Commission, has a very specific kind of expertise or category that we're looking at. So a primary care physician, a behavioral health care expert, a consumer advocate, a health economist, et cetera. There is Deb DeVoe is our esteemed chair of the board. And then I report to the board and I manage the day-to-day staff. In addition to this board, importantly, the board has pretty strict financial conflict of interest restrictions on appointments. So no board member can have any financial interest in either a health plan or a provider to create that additional layer of independence. But nonetheless, I recognize right away, we need to have those voices of our healthcare providers, our plans, the pharmaceutical industry. They need to also be engaged in the work of the organization. So I established an advisory council. That's a 30-person advisory council made up of representatives from across the care continuum and beyond, including small business groups, consumer groups, and patient advocacy groups. And I meet with them quarterly to help advise on our work. Next slide. So 12 years ago, we were the first state in the country to pass a law with this idea of a measurable goal, a measurable target for spending growth. And today, there are now 7 other states that have been inspired by our experience over these last 10 years and have put forward and passed either legislation or have had governors do executive orders to also establish, very similar to Massachusetts, healthcare cost growth targets and benchmarks that they would measure their state's performance against. As you can see, there is a little bit of a geographic trend among these states in terms of East and West Coast and the Mid-Atlantic. But I would say I'm really encouraged to share that I've had incredible conversations with leaders in many other states, Minnesota, Indiana, Texas, who are all really starting to think about healthcare costs in a different way. I think one of the principles that many of these states like about the Massachusetts model is that there is still a reliance on the private market. There still is a sense of private health plans and providers negotiating together. That this is not government rate setting. This is not government setting prices or fully or single payer. And yet we have this kind of enhanced oversight and enhanced monitoring, and to use data really as the foundation for inspiring policy. Many of these states are starting to go beyond what we've done here in Massachusetts in terms of some of the strength and tools to keep plans and providers accountable to these targets. And today, about 1 in 5 Americans live in a state with a healthcare cost growth target. Next slide. So I just said that we don't set pricing and that we provide this kind of enhanced oversight. how do we actually try to influence the behavior of our healthcare market to be able to meet this ambitious goal of being able to moderate healthcare spending growth? Well, we like to think of it in really 4 different levers. One is around our research and reporting, and you're going to hear from the leader of our research team in just a minute. But we think that there's a lot of power in being able to release really unique data analyses that provide us insights into the drivers and challenges and opportunities to find savings in our healthcare system. And David's going to talk a little about where we found some opportunities this year. We're also a partner. We have distributed over $100 million in grants to community hospitals and other community providers over the last 10 years. So we actually provide funding to organizations to allow them to test and innovate new ways of delivering care. Many of our grants have, in recent years, been focused on mitigating the impact of the opioid use disorder crisis and providing new ways of delivering appropriate care to those patients. We are also a convener. As Director Vino mentioned, just last week, we held our annual hearing where we have the ability to call the CEOs of the health plans and the CEOs of our major health systems to testify in public under questioning by our board. The questioning is under oath. And that is just one example of how we convene the broader healthcare community to try to, again, work together to identify opportunities and solutions. And then finally, and this is how the Boston Globe likes to describe us, is as a watchdog. We're an agency that acts on behalf of the consumers and the businesses and the people of this Commonwealth that are struggling to pay for healthcare costs and calling out market behavior by name that we think is inconsistent with our goals of being able to actually provide affordable care. So what do we do in this area? Some of the things we evaluate are hospital mergers and acquisitions, consolidation of physician practices into larger systems, capital expenditures and expansions. We sometimes will comment into the Department of Public Health. So really trying to keep an eye on how the organization and market of Massachusetts is changing and how are those changes impacting cost, quality, and access. So next slide. So that's great. So that was my introduction to the Health Policy Commission. I'm now going to turn it over to David Auerbach, who's going to share some of our most recent data about where we see some of the trends in Massachusetts.
Thank you, David. Hi, everyone. Good morning. Okay, I'm going to share some material mostly from our cost trends hearing that we had last week and our cost trends report, which we published in September. And I hope you ask me questions all the way throughout, anything at all clarifying or policy questions or anything. And I'll try to go through in about 20 minutes and we'll come back to David for some recommendations. Okay, so first you're seeing, as David alluded to, how has our performance been for the last 10 years against this benchmark target? The benchmark target is in the orange dotted line there, where it was 3.6% growth per year, and then it dropped down to 3.1 for a few years. And then you can see the actual spending growth in the whole state. And as you see, we've been above, we've been below. The last several years, we have tended to be above, and there's the weird COVID hiccup for 2020 and 2021, where we were down and then we were much higher. And we've kind of smoothed out that hiccup to show in that little blue line, averaging out the 2 years, and I'll be doing that averaging for some of this data that shows we were just a bit above for those 2 years taken together as well. And on the next slide, here I'm showing our commercial trend, which we focus more on at the HPC. We don't have as many levers with regard to Medicare and with Mass Health. The administration does a lot of Mass Health policy. So here I'm showing our annual spending growth in the commercial market, with Massachusetts in the orange and the US in the blue. And the striking thing to note is that up until around 2010, our trend was much higher. Then we were below soon after we established the HPC. I won't go too far on cause and effect, but we might have had something to do with it. But over the last few years, we've been back above the US trend quite a bit. That's 5.8% growth on average for those last 2 years. Next slide. And importantly, that growth is higher than inflation, is higher than wages and salaries. And you see that on this chart from CHIA, where they're showing from 2019 to 21, the cumulative growth in claims cost, which is your, the GIC, your self-insured employers who are paying the claims in the blue, and the fully insured premiums in the orange, compared to growth in wages and in inflation. And so healthcare costs have taken a larger share of income. Next slide. And if you add that up and show the long-term trend over the last 20 or so years, really the long-term trend is quite depressing, where you see premiums growing about 3 times as fast as inflation over this period, and twice as fast as household income has grown. Okay, next slide. And an important point that's maybe a little less important for the GIC is deductibles have also been rising. And so, as David said, when deductibles rise, you're shifting some of that healthcare spending away from premiums towards the consumer who's spending out of pocket at the time of using healthcare. And so the premiums are going up even as deductibles are also going up throughout the rest of the commercial market, where about 43% in total now have a high deductible plan by 2021. And so adding it all up, when you take the total cost of healthcare for a family, including the premium cost and the out-of-pocket, that totals over $26,000 a year in 2022. And that's an important number. It's a massive amount of money that we're spending on healthcare. It's almost as high as a full-time minimum wage salary for a year. And so on the next few slides, we wanted to break that down and understand, where's that money coming from? How do we pay this much money when it's just so high compared to our salaries? And where's that money going? Yes, please. Oh, no, I want you to. Yeah.
Sorry to interrupt you, David. I wanted to ask you, since the senior segment of the population is growing quite rapidly in terms of its need for health care, and to what degree does Medicare decisions impact what you do?
That's a good question. Well, here's something interesting. When commercial insurers think about how to pay providers and how much to pay for providers, they often start with Medicare. They piggyback on the way Medicare pays, because it's a lot of work. It's a lot of work to figure out how much should I pay for this MRI. And so Medicare has done a lot of the work in defining all of the codes and coming up with the way to pay, how much goes to the hospital, how much goes to the physician. And so private insurers will often do what Medicare does, but then add more, maybe double the amount, which I'll show you in a little while. And so there can be an indirect kind of policy link. For example, right now Medicare says, if you have an MRI done in a hospital versus a physician clinic, I'm going to pay more when it's in the hospital. It's the same exact service. They're right now in Congress thinking about maybe changing that policy, which would be called the site neutral payment policy, to say we're going to pay the same thing for the same service wherever it happens. That could lead, if they did that, some commercial insurers might say, okay, we're going to do that too. And there's some historical precedent where that has happened. So we don't have a lot of control over what Medicare does, but there tends to be this spillover.
David, what have been the recent trends in Medicare in terms of the spending of per capita spending?
Yeah. Medicare spending trends have been lower than the commercial trend in general lately. Even with this aging, they have been lower, partly because they set the prices. They control them. They can't grow faster than it's set in law, for example. So with that control, the spending tends to be more controlled as well. Okay, let's move on. And on this slide, I'm showing some additional detail beyond those averages, what I showed, the average premium being what it is. Of course, in the broader commercial market, some people are paying much more, some people are paying less. For example, on the left, we're showing that 10% of folks are paying premiums more than $31,000 per year, even though $23,000 is the average premium. 10% of folks have deductibles more than $7,000 per year. So there's a lot of variation around those averages too. That is really important for affordability, for equity, and so on. Okay. Next slide, please. So as to how do we come up with this $26,000 a year for a family? The blue is the employer paid portion, as you know. The orange is the employee portion that gets deducted directly from your paycheck when you elect to get insurance from your employer. And the yellow is the cost sharing. And that blue portion, I don't want to forget about. It's often invisible to people, but this is money that if I have a private employer, this is money that's not being paid to me in wages. It's going to health insurance. I'd probably rather have that in wages if it's not getting me anything in the healthcare realm. Now, with respect to GIC, I don't fully understand how the budgeting works, but of course, we'd like to not pay as much as we have to if we're not getting value for that dollar. Okay. And then as to where this $26,000 is going, we can apportion out what sorts of providers across the healthcare system, where's the money going? And the biggest chunk is there on the left, is the hospitals. These are in the form of hospital payments for inpatient stays, facility payments for outpatient visits. It's about $10,000 a year per family going to the hospitals in Massachusetts. And then you see the other chunks there, money going to the physicians, to prescription drugs, about $4,000 a year per family. There's the insured administrative costs on the right, and of course, other services, other providers. Yeah.
Can I just ask a question? So
Yes.
I'm curious if you put this slide up from 5 years ago, what the difference would be. And I guess what I'm trying to get at is more and more care being delivered in a hospital in the outpatient setting.
That's right.
At a higher cost.
That's right. That's absolutely true. It would be a smaller chunk 5 years ago, probably for two reasons, because more care is being shifted to the hospital, and also those hospital prices tend to rise faster than the prices in physician offices. So yeah, that's right.
And drugs would probably be smaller.
Drugs would be smaller, yeah. And I'll show you some growth trends in a slide or two. Okay. And now I'd like to put some of that spending in context of a family budget to think about affordability. What we've done here is shown a typical budget for a family of four in the Boston metro area on the right, how much average spending would be on housing, food, childcare, transportation, and so on, and then constructed some four-person families. So you see healthcare is on the top there, and some four-person families at different levels of earnings. And you can see that for a lot of working class families, those in the middle, you are just below that cost of living. And that means that they're making serious sacrifices to just live in this area. And we know this, we hear it about housing, it's everything else. But healthcare is adding to this. Healthcare is adding to this affordability challenge. And we heard at the cost trends hearing just a number of families who are deciding each month, am I going to pay the rent? Am I going to go see a provider for this healthcare problem? Am I going to have health insurance at all? And they're really making these trade-offs every day. Okay, next slide, please. So given that and everything that David Seltz said, the recent growth in healthcare spending just is unsustainable on many levels. And we have to try to find areas where we can spend less without sacrificing equity, without sacrificing value, quality of care. And we can do that. And I'll show in the next few slides some areas that we've explored where we could spend less without sacrificing those things. And that was the focus of our cost trends hearing. So before that, I'll just get to a little bit about where is the growth coming from, this high growth over the last few years. Prescription drugs is on the top, 7.7% growth per year. Hospital outpatient spending was the next highest. Again, these are minor surgeries, these are imaging, these are tests, things that happen in a hospital outpatient department. And most of that growth is coming from the hospital. Usually those services, again, have a piece that goes to the physician and a piece that goes to the hospital. It's the hospital part that's growing. And then hospital inpatient is also growing at 4%. And that's more striking than it seems because the number of hospital stays has actually gone down over the last 2 years. In 2021, there were fewer hospital stays than in 2019, but we still paid 4.3% more. And that's been a trend for a number of years now. And then Office-based care, regular physician visits, that is not growing as fast in terms of spending.
I was curious about the this data, and
Yeah.
on the very first slide, you showed that Massachusetts commercial spend is trending higher than the rest of the country.
Yes.
And so, is this is Massachusetts data?
This is Massachusetts now.
And
Yeah.
so, is
commercial?
So is it that is this similar to what's going on in the rest of the country? And it sounds like if it's not utilization, it's prices, and so does that suggest that prices are growing faster here than in the rest of the country?
It's mostly prices, and I think that's true, but I don't really have the apples to apples version of this breakdown. I wish I did. So probably, yeah. Okay.
Because Massachusetts is so concentrated in terms of healthcare providers and the recent and continuous mergers that are taking place make it even more so. Do you feel that the perception is that you don't have that many choices if you don't go to the hospital, because even in the community, the hospitals sort of reign supreme in terms of getting the best kind of care.
Yeah.
It's a lot of marketing that also impacts that in terms of how you get the care, and I think what happens also is that those individuals that can't afford to go to the hospital or see their doctor basically defer it, and then they get really sick and they have to go see the doctor, which means that the cost for them would be even more so because they are very, very ill. So the preventive care is not taking place either. Have you found this to be true specifically in Massachusetts, following Anne's question? Because I'm just wondering if it's true also in California, which also has a very major healthcare system, but it's more dispersed. Whereas in Massachusetts, it's very concentrated. So I was just curious how those kind of trends impact the data.
We do. That's a fantastic question. And a couple of years ago, we showed this in some pretty good detail, and we continue to talk about this each year. And here's an example. If we take all people with commercial insurance and segment them by their income, and we don't exactly know their income, but we know the income of the area where they live. And for the people who live in the poorest areas of the state, they have less spending on primary care, they have more emergency department spending and more hospital spending. They're not sicker. And you see the opposite trend if you go to the higher income zip codes. So I think that supports what you're saying. And we know that we sometimes have a problem with access to primary care, and we would like to improve that. We would absolutely like to improve that. I'm not saying if you added more primary care services, you would save money on net, but ideally, we would spend more there and less on the stuff we don't need. That's right. Okay. Here's kind of supporting the point that I made with Anna, where the driver of the spending growth is mostly price growth. And here we're looking at year-over-year price growth in inpatient hospital services, hospital outpatient, which we call HOPD, and in office-based services. And you see numbers here, they're growing, and they're in the 3-4% range. So that's most of the growth is price growth. Next slide. And I left out prescription drugs. Here you have prescription drugs. This is looking at gross prices, so we're not looking at the rebates here, but these average prices per branded drug are growing very quickly, 15% growth just last year. And so now the average price for a prescription, a branded prescription, is over $1,000. And 5% of those are over $5,000. And I know this is a big driver for the GIC as well. Okay, next slide. And here I want to pick on not just the growth in prices, but the level of prices. And in the next slide, we'll be talking a little bit more about this as opportunities to spend less. Here we've arrayed perhaps one of the most basic commodity-like services there is just a lab test, a lipid profile, hemoglobin A1C. We took 50 of the most common lab tests, made them into like a market basket, and said, I'm now going to buy those at all the different hospitals and the different providers that do labs across the state and compare how much it would cost me for the same exact basket of 50 labs. And you see that variation. It's about 6 to 1 from left to right. The blues are when you get these lab services at a hospital. The reds are in an office setting, or the yellows are in a place that is a big lab. That's what they are. That's what they do. You see tremendous price differences. And it's not just the total price that the insurer pays the provider, but the out-of-pocket portion also varies proportionally with this price. So if a patient ends up getting the labs done at the hospital, they are paying more too. That's that bottom portion. And I'm showing for reference what Medicare would pay is that gray for the same basket of 50 labs, okay? So this is a case where Medicare pays the same amount. They don't care where it's being done. Medicare says this is the price. And so you can see at some places, insurers are paying 3, 4, 5 times what Medicare would pay for the same labs. So we're going to pick on that in the next couple of slides. And what we did was we said, okay, part of excessive unnecessary spending is just paying too much for simple stuff. And we do a lot of that. We're going to say, let's set kind of a level of above which we think is paying too much and try to add up all the spending in Massachusetts where we're paying too much. How much is that? And we're going to set a benchmark level, not to confuse with the benchmark before, but a reasonable price level of double Medicare. Okay, and we're going to say, where are we spending more than double what Medicare would pay? Okay. Labs is going to be one example. Imaging is another example. And here's just showing, again, the array of prices we pay for imaging compared to Medicare. Medicare is 100% on this scale. 200% is where we're paying double Medicare. And there's quite a few MRIs where we are paying more than double what Medicare would pay. This is just unnecessary. It's just excessive money being spent on providers. Okay, so I've tabulated all these categories. We picked on labs, imaging, colonoscopies, inpatient stays, clinician-administered drugs, and prescription drugs on this table. And we showed, for example, 23% of all lab spending in the state is above this double Medicare amount. And part of what's interesting in this context is, for example, Oregon, for their state employees plan, said, we are not going to pay more than 185% of what Medicare pays, so near this 200% level. And they've saved a lot of money doing that. If we were to do that, on the bottom right corner, I'm showing that 12%, we would save about 12% of healthcare spending just for these things. This isn't all of healthcare, but these services collectively add up to about half of healthcare spending. So if we set it 200%, now I'm not saying this is necessarily the amount you would save. There would be some gaming, there would be some shushing around and whatever. But anyway, just illustrative of where we're spending too much.
I don't want to deflate everybody in this room. This is really good data, but I am feeling a little bit deflated in terms of, here we are again with some trends that are pretty high for spend, and it really impacts our members. So can you go back to the hospital slide?
Yes.
Where it shows the amount of money we spend on hospitals. One more, I think.
Oh,
it's way
bar
back.
Graph of the 10,000? Yeah.
What is the response of the CEOs of the hospitals in this state? I mean, we all love our brand name hospitals, and yet we've seen the data that shows that, if you go to a community hospital, you're pretty much getting the same care, more or less, plus or minus. Is it statistically significant? I'm not the health econ expert, but generally speaking, we pay more for our brand name hospitals.
Yes.
What is their response to this? Do they complain that there are fewer doctors coming in, so you have to pay for that labor? What is their rationale? Are they just not really good managers of and executing hospitals? Like, help me understand what are they using with all this extra money? Where is their money going? Do you ever get a chance to query them, and what's their response?
It's a great question. I don't know if I should try to reflect what their talking points would be versus what we know from some of the research. Maybe I'll stick with the latter. where does this money go? Here's one thing we know, because nobody wants to give up any money. I mean, I'm not saying anybody's bad. Here was an illustrative example. We showed some data on Rhode Island compared to Massachusetts. In about 2010, Rhode Island set an interesting, important policy implemented through their Office of the Health Insurance Commissioner, the Division of Insurance, that said hospital prices cannot grow each year more than X, and they set a cap. So what that meant was that hospital spending over the next 10 years in Rhode Island was limited. It only grew 20%, whereas in Massachusetts it grew 40%. So what happened? If you said that, if you said you were going to do that, most hospital folks would say, oh my God, you can't cut a penny from us. We need all that money. We're going to go bankrupt. What happened is they didn't go bankrupt. They cut their costs to be in line with their lower revenue trajectory, perfectly in line. So their costs grew 20%, while their revenue grew 20%. In Massachusetts, costs grew 40% and revenue grew 40%. So what the literature says and what that suggests is that hospitals in the long run will get as much revenue as they can and then find ways to spend that. And some of that spending improves patient care, and some of that spending is probably marginal. Some of it is on machines, on physicians, on capital expenditures, on marketing and advertising. It's all across the board. So that's my best take on how this works. Is that fair? Okay. Yeah.
So I had a question which you partially answered, but I'm very curious because I've noticed certainly since the beginning of the pandemic that the hospitals like, Mass General, Dana-Farber, they are doing more television advertising, which I hadn't noticed previously. Mm-hmm. And that I know is very costly. I don't know what that is, but I'm curious what the impact of that is on their costs.
That's a great. I've heard it too.
Okay, so
Yeah.
we know a lot of the other costs, like their expenses, the pay, salaries for CEOs, but I'm very curious about the impact of advertising, how much they spend, how much did they spend 10 years ago or 5 years ago?
I'd love to know how much that spending is. And we have hospital cost data, but it doesn't get granular enough to allow that. Maybe somebody here knows how to find that. I don't know how to find that. But part of the dynamic, part of why when I showed that price variation, why are those prices so high for some hospitals more than others? The dynamic is, if I'm a hospital, I want to make myself essential to that insurance company's network so that I can say to them, I need a 10% price increase, and they can't live without me. They can't say no. This is the leverage. And when I advertise and when I convince people that I need to have access to that hospital, then the insurer doesn't have a lot of cards to play. They kind of have to say, yes, I can't sell my insurance to my members without having this hospital system in my network. So the hospital then can raise its prices. Advertising helps me do that.
While we're picking on people, let's go to the health
Let's
plans.
do it.
I mean, that's, to me, they bring us products and they bring us prices with the products, which, by the way, they're not accountable for because we're self-insured. And isn't it their role as our agent?
Wait, I'm sorry, who's the who that they?
The health plans.
Okay.
Isn't it their role to basically drive down the cost and bring it into plans to people like us and do it across the board? I mean, what else are they there for?
That's a good question. I mean, the health plans would like to have lower premiums, but as I was saying a minute ago, sometimes when it comes to a specialty physician or a hospital, they just don't have ability to lower those prices. They just can't. A lot of them just can't. So they might find other things to do, like prior auth, denying claims or limiting coverage or moving around cost sharing, but their tools are sometimes limited in what they can do. Do people agree with that? Yes.
I have to say, I know there was a push a few years ago to have tiered products, for instance, on
Yeah.
narrow networks.
Yeah.
The problem is no one wants to buy them because they're concerned they don't get the big academic medical center systems in there. And so it's kind of a push-pull, right? I mean, until people are willing to buy those products,
That's right.
they don't.
And you know where they buy them? On the connector. The two most popular plans are the ones that don't include MGB, and their prices are about 15% lower. But there you're an individual, you're paying the full premium amount out of pocket by yourself. It's a hard sell for a lot of employers to get their employees to take up a tiered network or an air network plan when they're not even pocketing all of that savings directly. They don't tend to move the market very much.
So you made me think of a question. Have we done any market research with those consumers of the narrow networks that are part of the connector to find out, have they survived not having these expensive hospitals in their network? How is their care? Do they get prevention? I mean, it would be an interesting study,
It would be.
potentially.
I mean, I know there are insurance plan quality scores and quality measures. I imagine those are fine. I don't know that data. That would be what you're suggesting would be a great suggestion for the connector. I have no sense that the people fare any worse, but I don't know.
Well, with your health policy committee expertise and your very impressive board,
a good
potentially
question.
you might suggest doing that research. My second question
Yeah.
is more around how your testimony went in front of Congress, because our lawmakers might be able to make a difference if they took some of the actions that Rhode Island took and made a difference. I don't know how our lawmakers experienced your testimony.
It's a great question. I mean, maybe I should pause and shift to David to talk about some of our recommendations that really come out of this data. And I think I've gone through most of the data slides. Are there other questions still for me?
I just had a question regarding the prescription drugs, for instance, where and the advertising, right, and the number of people who want all these latest and greatest drugs, and the cost is like phenomenal costs, right, and unaffordable. And what I see are the pharmacies are denying those meds, and then people have to go through this very lengthy appeal process, and often are continue to be denied. And many of them, sort of need this medication. I'm not talking about the weight loss drugs, but or those weight loss medications that people actually need. So I'm very curious about that, because that trend is higher than almost anything.
Yeah.
And was part of your testimony related to prescription drugs and what can the legislature do? What are they able to do? And I guess to piggyback on Valerie's question, are they willing to follow Rhode Island and do something similar?
That's a good question. I think, David, why don't you respond to the prescription drug question and then shift to because it is more tricky, because it's a national market setting those prices. We have a little bit less control, but that doesn't mean there's nothing we can do as a state.
Great. Tagged in. So I wanted to respond to the last two questions and also talk a little bit about our policy recommendations and what we're going up to Beacon Hill and advocating for, because we do think that these trends are sobering, that these trends are unsustainable, that our current tools are not strong enough to moderate these trends. And unless there is legislative and policy action urgently, we will increasingly have a more and more unaffordable state for people to live and to get great health care. We really view this as an inflection point, is what we called it in our cost trends report, and that there is an urgent imperative for action right now. We've been at this for 12 years, and we've learned some lessons. We've seen this data, and on some of the things we just talked about, hospital pricing, hospital spending, pharmaceutical pricing and spending, I don't need a crystal ball to know what direction those trends are going to go into the future, especially on prescription drug spending. We know just from the pipeline of incredible biologics, innovations, curative orphan drugs and treatments that are going to be priced not at $100,000, not at $500,000, but over $1 million or over $2 million per treatment. And just a few number of those members in a self-insured plan can make a huge difference. So next slide. Well, I'll just wrap up with this last slide from David, which I do think kind of ties puts a nice little bow on this. So what we did with this thought analysis was just to say, what if we could bring down the total spending growth in Massachusetts from our current trend of 5.8% back down to what our target was of 3.6, the benchmark? And how much money could we save over the next 6 years? And so if we were able to bring that down to 3.6%, we would save over $22 billion over that entire period of time. Premiums in 2030 would be 14% lower than they otherwise would have been. It'll be more money in the pockets and in the hands of consumers and families, less medical debt, less avoided care. Just moving like a mortgage, if you can move those percentage points just a little bit, you can generate significant savings over time. And so that's why even with a growth of 3.6%, which by the way, some people would say is too high, given the very expensive state that we live in as a baseline, you can get some significant savings over time. Next slide. And one more. Thank you. And so just to quickly walk through some of these policy recommendations that we've made to the legislature. The first recommendation is around strengthening the healthcare cost growth benchmark. So we see an opportunity to do really kind of three things in tandem. One is to strengthen the tools by which we can enforce that performance improvement plan. I talked earlier about how that was one of the tools we had to ensure that payers and providers were taking the appropriate actions. It is a limited tool. As I mentioned, we've only exercised that authority once. And importantly, in the statute, there is some very technical language that means we're not actually evaluating individual hospitals in that. So we need to fix some of the language there. If a health system or a health plan, if we require them to do a performance improvement plan and they say no, our only recourse for non-compliance is a $500,000 fine. $500,000 fine for organizations that many of whom have over $1 billion a year revenues and much more is not a significant deterrent in my mind to ensure compliance with this law. Despite the fact, and I want to give credit to Mass General Brigham, who did and is implementing a performance improvement plan. Other states, including California, have introduced the idea of real financial penalties that would be commensurate with the amount of spending that they contributed that was over benchmark. And it's not so much that I think California and Oregon is also pursuing this, that they necessarily want to do big, huge, multi-million-dollar fines on the providers or health plans in their state, but they know that that will act as a stronger deterrent to get those organizations to do the right thing so as not to trip them into being into a place where they may have to pay out a very significant financial fine. We also think that there's opportunities to expand what we're measuring annually to include measures that are more relevant to individual consumers in terms of how they experience the affordability of care. As I mentioned, our metric is kind of all in total healthcare spending year over year growth, I'm telling you that doesn't mean anything to a family who is looking at what their premiums are, what their copay is, and what their deductible is. And so I think we need to keep those metrics close to our focus as well. And then finally, an opportunity to similarly set some targets and measurable goals for reducing health disparities and increasing access. Hi.
First of all, I want to commend the Health Policy Commission. You provide great data, and I think it's pretty eye-opening. And you may have been referring to me as one of the people that you have familiar faces, because as one who was intimately involved in the conversations about the cost benchmark, there were many of us at the time that said it should be about taking cost out of the system, not about moderating growth. And I think that was based on the fact that at that time, there was a lot of data that supported high prices, overutilization. Fast forward 12 years later, and the trend is pretty disturbing. And I think David Auerbach has just spent the past several minutes making a compelling case why we have to take cost out of the system. And so I guess my question, well, one would be a suggestion that as the data, a data point for next year, you talk about what the savings would be if the trend was just at the 3.6. I think it would be really interesting to know if the trend actually mirrored actual inflation. Because up until very recently, we had virtually no inflation, like what that cost reduction would have been. But I also would just see if there's any kind of thought about having a much more ambitious benchmark that isn't about cost growth, that is about taking cost out.
Yeah, it's a great point, Eileen, and I remember those debates vividly. I think as with all things, there was a compromise at the end of the day in terms of what this was set at. And I agree with you in that kind of thought experiment that we did around comparing trends. The 3.6 there is kind of meant to be a very generous target. You mentioned comparing to inflation, maybe comparing to just wage growth and salary growth. That, if that's another marker that you could compare that to and say, okay, what's a reasonable growth rate? How about the growth of how everyone's income is growing? Okay. So I think there's absolutely different ways to do that. We at the Health Policy Commission do have the ability now under our law to set the target at any number. It does require some legislative review. I think there has been some caution in recent years given the coming out of the pandemic and understanding just the shifts in utilization that occurred. But I think moving forward, there is an increasing emphasis that we need to be more ambitious in our targets and our goals. But we also need the policies to be able to do that. It's not going to happen on its own. And so that maybe brings me to my second recommendation, which is around provider pricing. And a recognition that the market alone, market competition alone is not restraining price growth. And so here we are recommending that the government consider establishing in law some limits on provider pricing. That could be done in many different ways. We're not super specific in this recommendation about this is the exact way we would recommend you to do this. In Rhode Island, it was an annual growth cap over time. Other states have looked at, and other state employee programs have looked at not so much growth, but the level, and saying we're not going to pay more than X percent of Medicare and just cutting off the top end of those pricing. So there's ways to do this. In addition, I do want to mention the site neutral payment piece and the facility fee piece here. We are making this recommendation to eliminate that extra payment that goes to hospitals for common services that are being provided in outpatient departments. We find that there are many residents who have no idea that they're going to a hospital outpatient department when they're receiving their care, and are often surprised to find a facility fee that's going to a hospital. Some of these locations are right on campus at the hospital, right? Some of them are far-flung, miles away from where the hospital are in suburban settings that you would have no idea that this isn't a regular doctor's office. And we're paying much more because of it's being operated under a hospital license. And you can imagine certain complex services where that may be appropriate, right? Where you'd want to have the standby coverage of the hospital. But we're talking about regular doctor's office visits, wellness visits, scans, labs. These are not complex things that need kind of the protection of a hospital license in order to be able to be provided at low price. So absolutely would think about site neutral payment. And then I do have 9 recommendations, so I'm going to move quick and just try to hit the highlights and then pause because I know we've already been here presenting for over our time. Okay. Number 3 is on prescription drugs. We see that this is an absolute area that is calling out for state policy action, and I'm very pleased to share with this group today that yesterday the state Senate did exactly that. They passed a comprehensive law on prescription drugs that would include a number of provisions relevant to our recommendation here. But really the prescription drug spending and market was largely not included in the overall oversight, accountability, transparency that we put in place 12 years ago. That was a different kind of oversight because it is a growing and important part of the healthcare dollar. We need to understand more about pharmacy benefit managers, manufacturers, wholesalers, and the entire chain in this pharmacy industry because it is a complete black box by design with a lot of money going in many different directions, often with the patient being the one to bear that when they show up at the pharmacy counter. So absolutely think we need to do a lot on prescription drugs. Number 4, health plan accountability. So here, we want to ensure that if we are doing something, say, on provider pricing and generating savings, that we need to make sure that those savings are not being just captured by the health plan, but are actually being then passed through onto the ratepayers, the consumers, the employers. So some opportunities for increased accountability. I would acknowledge and recognize Kevin Began from the Division of Insurance. They have already implemented some of our recommendations here about improving the annual rate review process and the transparency involved. So thank you for that. All right, number 5 is health equity, embedding concepts of health equity into all of our work, improving our data collection so that we can understand the disproportionate impacts of these policies and spending trends on many different populations, and putting in place policies that can think about the many different factors that influence health that are outside of the healthcare system. So a lot of work to be done here, great interagency work. I'm proud to be working with Director Vino, with the administration as part of a new interagency health equity task force. They have invited us to participate, and we are excited to report back about that. Number 6 is administrative complexity. We do see that there's some opportunities in just the very variable experiences of prior authorization, medical necessity utilization. There's opportunity to use technology to automate that. And there may be places to standardize across health plans. What are the rules that we're putting in place that would, again, provide maybe some relief to providers and to patients? Number 7 is about the provider market. I'll say this really quickly. This is a rapidly dynamic provider time right now. We are seeing closures at the same time that we're seeing hospital systems trying to acquire new community hospitals. We are seeing a new relationship form in the form of Beth Israel Dana-Farber and the proposed construction of a new 300-bed oncology hospital. We are also seeing the entry of more for-profit and especially private equity investment into healthcare in areas like skilled nursing facility, in areas like physician practices. And this recommendation really is around enhancing our kind of broader statewide market oversight to be able to put all those changes in the context of everything that's changing. We often look at things kind of individually, and those individual changes can add up to big changes over time. We just issued a report earlier this year about the pediatric market. and found that more and more community hospitals are closing their pediatric inpatient units at the same time that our big AMC anchored pediatric hospitals, Mass General for Children and Children's Hospital, are expanding. And each one of those little transactions that led to that point may not have triggered, a close review, but over time, we've seen a real consolidation of that care into a smaller number of high-priced providers. Number 8, workforce. This is a number one thing that we hear from providers, and is a contributing factor to their pressure to seek higher price increases. We think there's some policies to put in place to help alleviate the healthcare workforce. And then finally, at the same time that we think about maybe bringing down provider pricing that is not providing value, let's also think about reinvesting that in places that do provide value, increasing the proportion of the dollar on primary care and on behavioral healthcare spending. In the last few years in Massachusetts, the proportion of the healthcare dollar that goes to primary care is going down. It's now it's around like 7% of the healthcare dollar goes to primary care, and it's going in the wrong direction. This after many years of Governor Baker proposing policies that would have increased investment in primary care. Those were not adopted, but we see the opposite trend. And for a really well-functioning healthcare systems, we know that a foundation of primary care is really important. So thank you so much for this opportunity. I will stop talking. And very happy to engage in further questions and discussion.
Thank you so much, David. I think the Commission is doing an incredible job in giving us the data. This is so helpful in our discussions here. But I was wondering to what degree, I always found that in business, incentives are much more impactful than penalties. And to what degree have you considered public-private partnerships to provide the appropriate incentives, especially in areas that have the most need in healthcare, to prioritize that so that we could at least have an action plan for something that is impactful, that maybe can be a win-win to some degree, rather than just seeing costs increase. We know costs are going to continue to increase. And I think there's a need for motivation on both sides of the table as to continuing the quality of health care that we know that this Commonwealth is well known for, and how do we provide the incentives to also moderate some of the increases in costs that are taking place, at the same time being able to continue the quality of care, but doing it in small steps rather than a big thing that we wish we could have X. Yeah, we all do, but it's not doable. So I just find that if we could somehow determine public-private kind of incentives, whether it's taxes or some other kind of areas that the legislature could impact, I think would be extremely valuable, and also provide more hope for those that are not getting what they need, or the costs are way too high.
I think that's an excellent point. And I would look to some of the innovations that our Mass Health program has been doing as maybe a model for some of this. Through the financing agreement that we negotiated with the federal government, we have a lot of new incentive payments for providers that perform well, that they would be rewarded for performing well. There's specific incentive payments around help if providers are able to measure and reduce health inequities for their members, that they'll get incentive payments off of that. And I think that the idea that we have pursued in Massachusetts, even in the commercial market as well, around encouraging payer and provider contracts that are not fee-for-service, that are global-based budgets, that provide the incentive for providers to do the right thing financially. as well as kind of morally, right? That they would be rewarded financially if they're able to actually keep their patients healthy and well and out of acute settings. That model, that idea of value-based payment is still very much, I think, a part of the mix here. I think what has been frustrating in recent years is that adoption of those payment models has kind of stalled out. And it's stalled out at about 40% for a provider. And so a provider or a health system, they're kind of in this like no man's land, right? So, 40% of their contracts are about, helping them try to keep patients well, reduce costs, improve quality. And the 60% of their revenue is like, do more at the most expensive place at the most expensive setting. And I think we need to continue to make progress on that to switch those incentives, in order to realize some of the gains that you're suggesting.
Thank you, David. That's actually an excellent answer to that question. And the work that Mass Health has done around value-based payments, around greater coordination of care, accountable care structures through the waiver is actually one that we are sitting down to learn more detail about from our colleagues at Mass Health. And I put this in the category again of something that's really important to me and the leadership team at the GIC is leveraging the work of others, of our colleagues in state government. We certainly do it a lot on the work that you do, and I think the opportunities really are more than we could even do at the end of the day. And to that point, I want to make note that the whole concept of the benchmark, we have taken direct steps through our reprocurement and our contracting with the health plans to have that be a very specific feature of our expectations to our carriers and to hold them accountable to performance relative to the benchmark. So I think there are numerous opportunities here. I think the work that you all are doing around hospital outpatient departments, site neutral payments, very interesting to us. The work around affordability, we've actually setting of affordability standards as kind of a new metric. As we improve our systems to add race, ethnicity, language data, SOGI data as well. One of the things that we've considered in the past is gathering income data. And it's hard, right? Because we don't have access to that data, even of our members who are state employees. So, but we have a great deal of interest in that as well. So happy to have you sort of continuing to lead the charge there. So, thank you so much. This is always, we never have enough time to ask all the questions that we'd like to ask, but we'll look forward to having you come again in the future.
Well, thank you so much again, and thank you for indulging the Davids here this morning. I know you have other business on your agenda, but I just do want to extend again my hand in partnership and collaboration. You've given us some good ideas even today of some analyses that we're going to run, and I'll hope to come back and share those with you. So thanks again.
I don't know what this means for our rates for next year, but I hope the plans are listening and they're going to be very creative because our members, especially in those lower areas, and Bobby's shaking her head, she's worried about her members, and I'm worried about all our members. So let's move on to the next item, and that is our CFO. So take it away, Jim. I think the mics, yeah. It's so nice to see you, and we have plenty of time for you today.
All right. Well, nice to see you all. I feel like I'm teaching a class. Nice to see you all. Today we have a procurement vote that we're going to request from you. As you know, we need to procure all our vendors every few years. Both as best practice and according to our regs. And this procurement is for the healthcare auditor vendor. As you also may recall from prior meetings, we audit our health plans every 2 years on a rotating basis, and we contract with an outside firm, currently CTI, to perform those audits. And those audits look at their compliance with our contracts, our pricing, our plan design, federal, state laws, all of those things. For the first time this year, the audit is also going to include an audit of mental health parity requirements. Those are state and federal laws and regulations, and we'll audit our plans to see if they're complying with those. So, next slide, please. So this is a timeline of the project. It's taken place over the last few months. I won't read the slide to you, but Janine Dewar from our vendor management department managed this product and included members from the finance, legal, and vendor management team. Next slide, please. Well, then I'm going to pull an audible here and ask you to go one more slide, because this morning I decided this was not good. I'll go to order. Okay. We evaluated the vendors on their technical proposals. So this is their approach to the audits, the ability of the team, their history with clients such as us, their cost proposal. So this is a best value cost proposal, their price for doing the work, the value their team will provide, and again, their ability and the value they would add to the GIC. Their supplier diversity commitment, which we're familiar with from other audits, that the work the firm does, firms that help fulfill that commitment. Interviews were done with the finalists, and references were checked. So all these go into the scoring. As for bidders, we had 2 highly qualified bidders. As you know, we try to get as many bidders as we can. Last time around, I doubt you recall, but I do. We had 3 bidders, one of whom has left the market. There's been some consolidation in the space, but after we do this procurement, we will go out to folks that we know can do this work and ask them why they didn't bid, see if we can get some feedback on that. We do that pretty much every time. So we were happy with both bidders. Both bidders were highly responsive, highly qualified, certainly could have done the work. So we were in a good spot there. So we had a good competitive procurement. If we could go back to the prior slide. Thank you. So this is the scoring. Again, I just really want to stress that both firms were really outstanding. They responded well. Their teams were very strong, particularly in the mental health parity space. They both seemed like they could do that work. But we did score CTI as the winning firm. Kind of 2 differentiators there were their ability to provide legal assistance, so actual in-firm legal counsel we could talk to about the health parity audits. And they also provided some benchmarking that we find valuable against other agencies such as ours or in the industry in terms of the performance of the plans. So CTI is the recommended vendor for this procurement. And now if we could skip 2 forward, we could go to questions. Yes, of course.
Just a question. Obviously, CPI were high on the SDP, and
they were a little higher in the cost, right?
Correct. Yes.
So 2 questions. One is, what were the features of their SDP plan that were, required a high score? And the other is, what's the cost difference in real dollars?
Sure. Mm-hmm. So the SDP is the commitment of not just the work they will do on this contract with firms that help them fulfill their SDP requirements, but their total book of business. So they just have a higher spend in their total book of business across all their work. So they contract with more vendors that fit into those categories. So that's the basis of that. On the spending difference after BAFOs. So after BAFOs, prices went up and down with both firms, but it's about a $40,000 difference, so $10,000 a year between the 2 firms. You're welcome. I'm happy to answer any other questions about the procurement or the audit process itself. As you know, in September, we will be back with the next set of audits with whichever firm wins.
Actually, I have a quick question. Thanks, Bobby. With CTI as the incumbent, are there any concerns with the services they've provided previously? And if so, were they able to address those?
Mm-hmm. That's a great question. They've overall done an excellent job, and I would, if I were grading them in this class, I would say they've been B plus A minus performer. They have had some staff turnover, which isn't unusual. They handled it well, but we did have to monitor that with them. Couple of more experienced auditors moved off our account, but they did move staff that we found acceptable back onto the account. They performed the last audit with that staff, the last audit cycle, and did very well. So yes, those are major concerns. Staffing across All the financial vendors is very volatile these days, and they're experiencing that as well. They were also purchased or sold, I don't know which way you want to look at it, by a larger firm. So they're part of a more corporate umbrella. We need to ask some questions around that, but we're very comfortable with that arrangement.
So, actually, one of my questions was answered already, but thank you. So I'm sort of very curious. So they're going to sort of be tasked with auditing CVS, right? Who's our pharmacy benefit?
Pharmacy is included in this.
Right.
In this
So they're
procurement,
going to be doing the retail as well as the mail order, all of it.
They would do all of it. Correct.
Will they also look into the appeal, number of appeals and denials and
Yes.
justifications and
Yep.
for all that?
Right. That would be payment compliance, and that's.
And
sure.
the behavioral health, right?
Correct.
Those are the two big areas. Okay. All right. I just wanted to make certain because
No,
it was
good
a
question, good
big
clarification.
disparity.
'Cause
Thank you.
I didn't mention the PBM
Thanks.
portion. Yes. Oh, I don't want to.
So, does CTI audit any of our insurance companies that we work with?
Other than for us? Yes. They
Yes.
do. They
And how do they address conflict of interest?
Well, they're required to, and I would defer to counsel if needed here, but they're required to declare that with us if they have any conflicts of interest and rectify them. And they've never had a conflict of interest that they've brought to us.
Any other questions? This is good discussion.
Good discussion.
All right, well then at this point, I will entertain a motion to give the GIC staff to go ahead and contract successfully with CTI for their services beginning in January. Okay, all in favor? Raise their hands. Remember, we have to raise our hands. And Andrew has to count. And it's unanimous, so the motion passes. Thank you very much, Jim, for the hard work. Thank you to everybody who served on the decision committee. And go forth and negotiate.
Thank you very much.
Yeah.
Appreciate it.
Do you want to stay up there for the
I'm going to stay
CFO
up here
report?
and do the CFO report. If
Okay.
That's all right with everyone. Okay.
All right.
As you know, we are through the first quarter of the year, a little more than the first quarter, first 4 months of the first third of the year. That's the math. And we're generally on budget. That's the top line. We're spending more or less as we expected to spend. I would caution you again that particularly this time of year, what we have are paid claims. So there's not a lot of insight we can make from that. We'll get the data in our data warehouse. And as you might recall from prior year cycles, we'll come with more information as to what the drivers are. But there are some things that we can talk about here. But first is the informational things that you have in your packet, so I won't read through them. But these are the vendors and what we paid them from the state share of premium accounts. And if you go to the next slide, please. And these are what the employee share paid, so what the employees contributed to the payments to each of the vendors. Next slide, please. So this is the budget to date, the shape of it. And as you can see, we've been more or less on target as to how we projected this year to date. And one more slide, please. And this is the projection, as you can see. I think it's a blue line. I'm having trouble seeing from the side. But the line that goes through the whole year is how we project the spending to be as the year goes on. And as you know, as the months go by, we'll match that with what our actual spend is, and we'll be able to see if we've missed on the pattern or if there's some anomalies there. Okay, next slide, please. And as you know, this is our additive budget, so our cumulative budget. And again, this is a good demonstration of how large our budget is. Our spend is very big. So even though we do have some variance, overall, we do trend right on. These variances are small compared to our total spend. Next slide, please. So this is the bottom line through November. We were $18 million under budget. And that does not mean we'll end the year that way. That is just, we projected through the first 4 months. A couple of things and that's about 1.8%. That's within our normal range, but a couple of things that we projected that were a little different were the PBM spend over the first 3 months we projected to be a little higher. We did factor in the fact that people would do fills before the vendors changed, but we think there was probably a little more of that than we put in our projection. So that would be something that would work off during the year. So again, I wouldn't forecast this as the surplus for the year at all. We also saw a little less utilization in the plans than we forecast, but again, early, that could even out over the course of the year. And with that, that's the first report of the year. Again, we'll come back with more detail as the year goes on.
Jim, thank you. How does this year's sort of trend compare to last year at this time? I'm curious, like the expenditures.
The expenditures.
Yeah.
Everything's higher, right? Prices have gone up, as we heard from our colleagues from the other agencies. So we forecast everything. The whole line went up of spending for the whole year, if you will. Although we're on budget, we're spending more. I mean, the budget is more for this year.
So is it more due to inflation?
More pricing than utilization is what we forecast, right? More for the pricing. We don't see people using less healthcare, and we don't want that, right? But we
Right. I was just curious sort of where the
pricing
yeah.
is where the pressure is. Yeah, it's unit prices. Is
Okay.
the driver.
All right, thank you.
And drug prices. When I say unit prices, I mean both.
All right, thank you, Jim.
Thank you.
Do we have any other business to discuss? Did you all enjoy being here in person? It's very nice to see everyone. The engagement is definitely higher. My eyes don't hurt as much after 2 hours in front of the screen. So we will meet in December by Zoom on December 21st. We will be live streamed, and the staff will be hard at work talking to plans, asking them to be innovative with the help of WTW, our esteemed broker, and we appreciate that very much. And so unless there's no other questions, I can let you out early. For a few minutes. So I do need a motion to adjourn. Do I have a second? Second. All in favor? Anyone opposed? All right. Well, then have a wonderful Thanksgiving. I am grateful for all of you and this opportunity. And Erica is encouraging me to bang the gravel. Bye, everyone.